Good morning, everyone. I'm Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we want to welcome you to today's webinar entitled Wraparound Services for Adults with Behavioral Health Conditions with Julie Radlauer-Doerfler. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in a listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel rather than the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them, and the presenter will address them as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are also posted in the chat panel. If you continue to experience poor audio through your computer, you can try rejoining the webinar and call in using the telephone I will call in option. You must be connected to both the audio of this presentation and view it on screen to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. However, a PDF of the PowerPoint has already been uploaded if you would like to print that. One helpful hint is the archive video displays what looks like to be an error message, but it's only a delay buffer, so you just want to ignore it, hit play, and enjoy. To access the recording and PowerPoint, you would go to our website, www.fada.org, Resource Center Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Thursday, August the 20th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx does monitor your arrival and departure, so it's important that you attend the entire webinar. WebEx does provide a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to give partial credit. And now I would like to introduce our speaker today, Julie Radlauer-Doerfler. She's the principal of the Radlauer Group, has 25 years of extensive experience in the field of both human services and organizational development. Since the inception of Radlauer Group, she has been involved in various projects, including training in the evidence-based practice of wraparound, system planning and integration, strategic planning at the system level, grant writing, assisting organizations through the accreditation process, training, coaching, and providing technical assistance and teaching leadership, with a concentration on strategic planning, curriculum development, continuous quality improvement initiatives, and conducting large-scale organizational and system assessments. The Radlauer-Doerfler Group has assisted numerous individuals, organizations, and systems of care attain their goals. And with that being said, I would like to go ahead and introduce Julie. If you're ready, we'll go ahead and pass the presentation over to you.
Good morning, everybody. I figured I would come on camera and give you a chance to see me. Sadly, I can't see you guys, but that's the state of our current affairs, right? I probably won't be on camera the whole time, but I just wanted to kind of say hello and welcome, and let you see a face to a name for a moment there. Thank you, Karina, for the introduction. As Karina said, my name is Julie Radlauer-Doerfler, and I'm with the Radlauer Group. And she gave a really nice introduction about what the Radlauer Group does. I'm here today to speak with you about the wraparound process, and I've been working through the Department of Children and Families in the state of Florida for the past several years to implement and scale wraparound across the state of Florida. Today, I just want to talk about our learning objectives, what we hope to accomplish today together. So the first thing is that we're going to talk about system of care. We're going to talk about recovery-oriented systems of care. Now, recovery-oriented systems around value and principles closely aligned. So across the state, when you guys are being asked by the Department of Children and Families to implement ROSC, really wraparound is kind of the practice level implementation to ROSC principles. So at the client level, wraparound helps you achieve those recovery-oriented systems of care principles, right? We're also going to talk about some of the facilitators and barriers to implementing wraparound, which really means we're going to talk about the things that providers find easy about implementing wraparound, and then we're going to talk a little bit about some of the challenges that providers have expressed around implementing the evidence-based practice. And then we're going to just increase our understanding of what wraparound is and how you can learn to adapt it within your organization. So, why am I here? I'm here because the state of Florida has made a commitment to transform the mental health and substance abuse services that are available across the state of Florida, within the state of Florida, right? And they've made this commitment to make sure that services are family-driven or individually driven, and that there's a strong focus on prevention, recovery, and resiliency, right? And the reason that the state has really made this commitment is because that we believe that services and supports should be person-centered, community-based, and results-oriented. And for our purposes, person-centered really means that services are provided with a combination of both services and supports that really respond to the individual needs that people have, as well as using kind of their strengths and their support systems to help them meet those needs. And services and supports should be designed by the person served and closely aligned with what that person wants to work on. Additionally, public health and public mental health systems really are driven to recognize, respect, and address the differences of people's gender, age, race, culture, religion. All of those things are really important to make sure that we're treating the person holistically, if you will. So I talked a little bit around recovery-oriented systems of care, and I figured I'll explain to you what that really means. The recovery-oriented systems of care, and this is was, a quote by William White, who's one of the founders of this recovery-oriented system of care movement. It focuses on a combination of both formal as well as informal networks that people can utilize during challenging times so that they can achieve long-term recovery and sustain long-term recovery for people that have mental health or substance use conditions. It's not. So when you think about ROSC, it's not like a service that's being provided. It's actually almost a philosophy, like a macro level philosophy that all services should be provided in this way, using these values and principles and standards, right, and elements, if you will. And so the elements of ROSC really refer to that we're looking to integrate and mobilize community for the purpose of creating a healing opportunity for people. It's really important that family is included in this process whenever possible. I know you guys, I'm assuming most of you guys work with adults, right? And so it's in the children's system, of course, you end up having to work with families. In the adult system, maybe people have lost touch with their family, or they don't want their family involved. And so it's a little bit more challenging, but nonetheless, we get better results when people have access to services and supports. And support really comes in, when people are connected to their family. So we really strongly encourage people to help the clients that you're working with reconnect with family if they've lost connection. And that becomes part of the process, right? Because we're looking for that long-term sustainable outcome. Also, recovery-oriented systems of care require that we focus on a culture of peer support. For people that don't have support in their lives, maybe they don't have any family or their family really is not a possible connection, then we have to help them get connected to people that will support them. And so peer support in the adult system is an excellent mechanism. And so ROSC and Wraparound strongly include that peer component. We value transparency. And so gone are the days where, as a clinician, I would have an opinion about a client and not tell that client my thoughts or opinions about them, right? We need to be able to be upfront and open and honest and just help people through those relationships that we create to help facilitate change with people, not for people, right? ROSC as well as Wraparound really focuses on like the whole person, so that holistic view that's individualized to each person based on the things that they're interested in and the supports that they have so that they can recognize recovery. We look at people that are experiencing mental health conditions as this is what's happening for you right now in your life. And together we can help things stabilize a little bit better. And then hopefully in the future you won't have that same experience. And it should be equated almost to say, like, if you're dealing with somebody with a physical health condition, like, for example, diabetes. Somebody who has diabetes, is there a person living with diabetes? Sometimes their diabetes is in check and they're stable. And other times, maybe they're eating what they shouldn't be eating, or their body has changed and the amount of insulin that was acceptable in the past is no longer acceptable. So they have ups and downs, right? And sometimes they're completely stable and there's no challenges. And then other times, they're having a difficult time and they're not feeling well. They might get hospitalized, right? But then we work to, with them to help them get to a new homeostasis, a new place where they can be stable. And once we've achieved that, then things will get better for them, right? And so mental health really needs to be seen in the same vein, right? And we're looking to create changes when people need changes and stabilize systems and families and people when they're doing okay, right? And so that's that recovery-oriented system of care approach, right? That people will recover from what's currently happening in their lives. Also, we're looking for and encouraging opportunities for support. And we're going to spend a little time talking about support because that's a huge piece of both recovery-oriented systems of care as well as Wraparound, right? We are looking to use data to inform the choices, which is really important. So if somebody's, say using substances and they say, yes, they do want to stop using substances, but so we'll track how many times they were using substances before they made that commitment and then after. And we don't expect that just, somebody who's been an alcoholic for 10 years is all of a sudden is going to go 30 days without drinking. That's unrealistic. I know that sometimes we have contracts that say that, but in reality, if you can decrease that amount by looking at the numbers, you can see that they are making improvements and celebrate those improvements, right? So recovery-oriented systems of care, as well as Wraparound, strongly promotes hope, right? So hope for a better life is something that's really important to this process. Okay, so when you look at this map, recovery-oriented systems of care is something it's a statewide Florida initiative. But here, when you look at this map, this is a map of the United States, obviously. And you see that some of the states are blue and some of them are yellow, not to be confused with politics, right? And the blue states represent that the blue states represent states where Wraparound has been implemented across the entire state, right? So a statewide implementation. like I said, my responsibility for the past couple of years has been to statewide implementation of wraparound in the state of Florida. So you can see we're represented as a blue state, right? The yellow states represent where wraparound is provided in a jurisdiction. So one jurisdiction or another. So maybe like Palm Beach County, or it could even be within a region, like so the southeast region of Florida, but not across the whole state, right? But the reason that I show this map, not is to differentiate between necessarily the blue states and the yellow states, is to help you guys realize that wraparound is evidenced in every state across the United States, right? And that's adult wraparound, children's wraparound. Wraparound was initially geared towards children with complex behavioral health conditions, but at this point it's been expanded and wraparound's available for adults, children, different populations, people transitioning from jail. It's, you know, we've really amended it. And to help you further understand what the state of Florida has done is, you know, made a strong commitment to the implementation of wraparound. This is a quote by Uta Gatzioch from the Director of Substance Abuse and Mental Health at the Department of Children and Families. And she's been a wraparound champion for a really long time, which is great, right? Because she's been able to be very instrumental in making sure that wraparound is evidenced across the state of Florida. So there's some standardization in our processes across the state, and regardless of where you're providing services, you have access to information about wraparound. So you guys, I'm assuming that most of you guys are, you know, in the state of Florida. If you want to just take a moment and in the chat box, go ahead and type in, like, you know, who you are and where you work, you know, what part of the state you work. And if you're outside of the state of Florida, you can tell us, you know, where you are from the outside of the state of Florida as well. I'll just kind of peek in the chat box. I see a couple of people have already kind of checked in. Somebody from Miami. And okay, so Cocoa Beach, Florida, Miami, and somebody's from Utah. Hi, Utah. Key West, and from Palm Beach County, from Jacksonville. So we have people from all over the state of Florida, which is fantastic, as well as people from other parts of the country, which is great too. Nice to see some friendly faces, or friendly words, I should say. Which, you know, so welcome everybody. Okay, so let's start talking about a system of care. So what a system of care does, and remember, this is in context with recovery-oriented systems of care, right? The system of care is really similar to a recovery-oriented system of care. The difference is that a system of care kind of takes it down from less of a philosophy to more of a community-based supportive movement, right? And so the system of care focuses on that network of the combination of both formal and natural supports, and how people kind of come together to create this integrated system. But even beyond that, beyond, you know, that integrated system of services and supports, a system of care really is just basically like how a community takes care of its own. You know, how we make this commitment that adults with behavioral health conditions living in the state of Florida will have support. That's a system of care. And then if you want to take that down even further, you can say, okay, well, adults living in Panama City, adults with behavioral health conditions living in Panama City will be supported by the services and supports that are, you know, both, you know, living in Panama City, and so the formal as well as the informal, and that combination, right? And so we make that commitment that people living in certain communities will have the services and supports that they need to have a better life, right? And that's kind of what that overall system of care approach really talks about. So let's talk about the core values of system of care. So core values for system of care really relate to that services will be guided by the individual, right? They'll be guided by the family and by the individual. This slide speaks about children, but really it should just be adults or individuals, right? And it's that we're no longer going to tell people what they need to do. It's about what is it that they want to do, right? And as a professional for so long, we've been in this position where we feel like we can tell people, oh, well, based on my opinion, I think that you should go here or you should do this. But at the end of the day, we could recommend things, you know, all day long, and people choose or not choose to do them. And we get better outcomes when people make those decisions themselves, right? So we have to kind of take a step back from the expert role to then ask people, well, what is it that you want to focus on first? What's the most important thing to you? And help them achieve that, right? And we have to have the faith that the people that we're working with, that the choices they make are good. And sometimes they're good and sometimes they're not good, right? And so when they're choosing to go in a direction that maybe is not quite as in the direction we would hope that they would go in, we have a conversation about that. But what we've learned through the years is that we can go ahead and make referrals all day long, but if somebody's not ready to make that change, they're not going to do it, and so they won't be successful. So the way to get around that is to make sure that they're the ones that are driving the process, right? And that's what the research shows, right? Additionally, when we're talking about the core values of system of care, we're looking for people for services to be provided in the community where people live, work, and thrive. And so we wouldn't necessarily want somebody that's living in Orlando to have to receive services closer to Tampa. Like, they wouldn't go. So I wouldn't go, and so they wouldn't go. Right? That's too much of a commitment. And also, this speaks to that we don't want services provided in a residential type setting or in the hospital type setting. We want services and supports to be available in the communities in which people live, because that's how they can create kind of that support network, right? Which is what we're looking for, is that ongoing support network. And which is a little bit different for many of us as professionals. I'm a licensed mental health counselor. And as a professional, I feel like, okay, well, if somebody needs help, I'm going to make a referral for a formal service. But what Wraparound and what System of Care talks about is, if people are more connected to supports and services within their own communities, they don't need those formal services, right? So if a client that you're working with is really interested in gardening, and you can connect them to a gardening club in their neighborhood, there's a greater likelihood that that connection and the relationships they make through that connection would stop their need for maybe going to see a therapist weekly, because they're getting their needs met through other ways, right? And that's what we look to partner with the client to figure out what is it that they're looking to add to their life, right? Another core value of System of Care is that we're being culturally and linguistically competent. And so what this really speaks to is, on the surface level, we're talking about language, right? If I speak Spanish, then I want to be connected with the Spanish-speaking service provider. That makes sense, right? But then also that not necessarily like matchy, like if I'm African American, then I have to work with somebody who's Black. Not that. It's more about an understanding of people's culture and what culture means to people, and making sure that whoever is being a service provider is able to address the cultural needs of that client. And so cultural needs means a lot of things to a lot of different people, and we're going to spend a little more time talking about it. But it's not just, race or ethnicity. It's deeper than that, right? It's the culture of how decisions are made. It's the culture of what that person prioritizes and how they prioritize it. It's the culture of how they accept support and how they want to be connected to people, and how they communicate with people, right? So culture in System of Care, and specifically in Wraparound, is very broad, but also a very integral part of the entire process. Okay, so let's talk about this for a minute. In order for Wraparound to really be successful, they have to have involvement with multiple different levels. And by levels, we're talking about involvement, right? So at the bottom, that blue effective team level that you see, that's what we're talking about today, right? That's the service of Wraparound. So in order for Wraparound to be successful, people have to be trained in how to implement Wraparound. And so for case managers or therapists or even peer specialists, whoever is going to be implementing the Wraparound process, they need to be trained. And the training for Wraparound is a 3-day 101 training that's been approved by the state of Florida. If you're curious about getting training, you can contact your managing entity, because we've created kind of a sustainable opportunity for training and coaching across the state of Florida, right? So you have to have service providers who understand what Wraparound is, who have bought into the team-based approach and can implement the model. Additionally, though, you also have to have the support of an organization, right? So if I'm a case manager working within an organization and I'm trying to follow the values and guiding principles of the wraparound process, but my organization won't allow me to do so, right? So we talk about some of those barriers to implementation. A barrier might be, for example, that wraparound's a team-based approach, and so everybody who's involved in the life of the client should be involved in a team meeting, right? Every professional as well as natural supports. And so, for example, a provider might have a case manager say, okay, well, the case manager can be at the meeting because they're facilitating. But then if the client also has a therapist, then you can't bill for both at the same time. You can't bill for a therapist and a case manager at the same time through Medicaid. And so there becomes a barrier to everybody being at the same table. And so an organization who wants to implement wraparound has to work through those barriers and figure out how to how to create this funding mechanism so that everybody can get reimbursed for their time. And there's a way to do it. And so we work with each organization to help them figure out what that looks like for their organization, right? If you have an organization that says, well, no, if everything gets paid for their time to be in a team meeting so they can't go to a meeting, well, then that organization is not supporting the process, right? And you can see how it would be difficult to implement wraparound when the organization hasn't bought into what's required of the process. And then lastly, is that there has to be collaborative system level, coordination and integration at the system level. And so what that really means is everybody who works within different systems in the community in which that client lives and goes to services needs to understand what wraparound is and support that process. So, like, for example, if you're dealing with an adult who's involved in the criminal justice system, well, the criminal justice system should be aware of what wraparound is and understand how they have to participate in a team. So the probation officer might go to a team meeting, right, and recognize that that's part of the process that their client is going through. And so this collaborative system level is really important when you talk about facilitators and barriers. Specifically facilitators, right? So we can have wraparound implemented at a much higher level when we have collaborative system partners at the table. And that's what's really important about recognizing that there's 3 levels and all 3 levels have to be engaged in order for success. And that's part of what I've been doing for the past couple of years is going around to all the different regions and working at that system level to try to get system partners to collaborate in this and recognize the value and their role in the process. Let's talk about why wraparound or when wraparound really, right? So if you look at this slide here, you see that on the bottom part, the green part, 80% of the population, right? This represents the population of the United States. 80% of the population is able to address their mental health or substance use conditions through what we call primary prevention or universal well-being. And so most of us fall into this category, right? And that means that, yes, we might be experiencing some mental health or substance use conditions. And when we feel like we need help or support, we can get our needs met through community-based initiatives. So that might be something like going to a yoga class, right? So that's kind of primary prevention. We're staying ahead of the challenge. I'm having a really difficult day, and I'm going to go for a walk with a friend, or I'm having a really difficult day, and I'm going to call somebody and talk to them. Right? It's through my support systems, and I prevent, this is like self-care. I prevent myself from needing further services and support because I'm able to meet my needs at a lower level, right? And then we spend about 5% of the dollars allocated to mental health and substance use conditions on this 80% of the population, right? So now look at this yellow level. When you look at the yellow level, it represents about 15% of the population. And so people in this 15% of the population, they have their mental health and substance use conditions addressed through early intervention type work, family preservation type services. So this might be going to an outpatient counselor, going to see a therapist, or going to a psychiatrist, but only a psychiatrist and not needing more than that, right? So that early intervention type work, we spend about 35% of the dollars on this 15% of the population. Now, if you look at this top red level, this is, represents about 2 to 5% of the population. And this top level tends to be probably the clients that most of you are working with, right? It's the more severe children and adults. They are severely emotionally disturbed, the SED, or emotionally behavioral disturbed, EBD, or for adults, it might be like the severe and persistent mentally ill, like the SPMI. These are individuals that are being hospitalized frequently or at risk of going into some sort of residential type placement, right? So this higher level, this top part of the triangle, again, 2 to 5% of the population, right? So it's not everybody. It's the people that have multiple system involvement, or what we call, they're complex, right? So there's multiple things happening with them. The combination of mental health, substance use, or even mental health and physical health sometimes, is complex. It's, again, 2 to 5% of the population, but we spend 60% of our dollars on that. And so from a level of we don't want people to have to become so severe in order to get their needs met, right? In a perfect world, we would be intervening powerfully at the yellow level to prevent people from even going into the red level, right? And when you're implementing wraparound, you tend to work with people that are at this 2 to 5% to get them back into this yellow level of care, right? And that's what we're striving to do. So we've been dancing all around the topic of wraparound, but we haven't really said what it is. So this is what wraparound is, right? It's a process. So it's not a service. It's not a program. It's a process, right? It focuses on the strengths of individuals, the needs of individuals, and their culture. And again, culture is infused throughout, and we'll talk about that. The process supports what's called an integrated plan. And what we typically do with complex adults and children is they're involved in multiple services or multiple systems, and each system has a plan. And so on my plan, my behavioral health plan, there might be 3 goals that the family's working on. And then in child welfare, or in if the parents are involved in child welfare, they have a case plan. And from that case plan, there might be 3 or 4 goals that the parents have to work on, and the adults have to work on. And then if there's criminal justice involvement, then they have a probation plan that the parents have to work on, or the adults have to work on. And so that's, the family ends up having to work on multiple things because we're not integrating the plan. So with wraparound, we all sit around the table and everybody says, well, he needs to do therapy for this in order to get his children back, and he needs to do anger management therapy in order to drop his criminal justice charge. Let's make that the same therapy. Let's have him go to 1 therapy instead of having to go to 2 or 3, right? And that integration creates a successful environment, right? Also, the individual is the one who's driving the process regarding the vision that they have for their future. It's not what we as professionals tell them they have to do. It's what they as human beings decide that they want to do. And we're here as facilitators, but really they're the ones driving the process. And again, our systems, if you talk about facilitators and barriers, our systems create barriers to that, because when there's jurisdiction involved, when something is being court ordered, we're telling people what they have to do. You have to do this in order to get your children back, or you have to do this to get off of probation. So that's not their vision. That's our vision for them, or that's the judge's vision for them, right? And of course, they do have to do those things because some of their actions have resulted in poor choices, right? The choices that they made, then these are the consequences for those choices, right? But at the end of the day, they have to decide what direction they want to go in, and we're going to help them get there. And that's what wraparound really focuses on. And then finally, wraparound is what's called a teaching model. So we're not looking to get in there, stabilize the situation, and get out. Because when we do that, the next time that there's a crisis, they're going to need us to get in there and stabilize the situation and get out. So what we look to do is we look to educate them along the way, right? So we're going to be working with them to teach them new skills so that they can do the things that will help keep them out of trouble in the future, right? So they can learn how to manage their own crises. They can learn how to ask for help, or to look up a resource so that they can find food. We'll teach them these things so that they can become, show us that they have the new skills, show themselves that they have the skills so they feel confident, and that they can be independent in the future. And, that last piece that I was just talking about is the most important piece of wraparound. It really just speaks to, we begin with the end in mind. We help the client identify what is it they want to work on, and we help them get there. And in wraparound, we talk about this language called purposeful transition, which is from the very beginning, I'm teaching you something so that you can be successful on your own, right? This is the goal, is I want you to learn these skills so that in the future, you'll be able to help yourself meet your own needs. let's just talk about the principles of Wraparound for a second. If we weren't on a webinar and there were so many people on this webinar, we would be doing this as an activity, almost in a breakout session. But because we're here, I'll just go ahead and talk about it this way and kind of help you understand what these principles mean. So the first one is voice and choice. And that really refers to that people have a voice in the process, right? We don't allow them to have a voice. It's their voice. We're a part of their process. They're not part of ours, right? So they're the ones that are guiding the process, right? Also, that services will be provided in a way that's culturally competent, which means that we have to recognize and listen to the people that we're working with and find out what's important to them. And interestingly enough, I've been having a lot of conversations lately around this principle of culturally competent because it's something that's been coming up a lot, especially in the youth field, right? When you're working with teenagers and young adults, and what's happening with racial injustice and social injustice in the world. And that's part of culturally competent, right? So we as professionals, we have to learn how to have those difficult conversations, right? They might be uncomfortable for us. They might be uncomfortable for the youth. We shouldn't ask them to have a conversation with us. It's if they want to have this conversation. But we have to figure out how we can have these difficult conversations, because if somebody's really being impacted by racial injustice or social injustice, and we choose not to have that conversation because we're not comfortable having that conversation, it's a missed opportunity for creating a support system for engagement with that client, right? So we have to be able to recognize what's happening in the world of the clients that we're working with, and what do I need to do to support them and help them, right? And it's not about what I believe as a professional or anything like that. It's about them as a human being and how I can use my relationship with them to help them, heal, to help them get through whatever challenge that they're having, right? And so cultural competence is not just about the color of somebody's skin. It's also about their beliefs. It's about their habits. It's about the people that support them and how they want to give support or receive support. It's about the holidays that they celebrate and who they celebrate those holidays with. And most importantly, it's really about support systems. In Wraparound, it's mostly about support systems and creating sustainable support for people, right? The next principle is individualized, and that just means that it's not one size fits all, right? So every client that's experiencing bipolar does not have to go to therapy, right? Every client that's experiencing major depression does not have to do ECT, right? So whatever this client has this diagnosis, the intervention for this diagnosis, that not necessarily. We see people as individuals, and we try to help figure out, well, what drives this person or what makes this person feel good, right? So I might think that this person really needs to go to therapy because they're just, having a really difficult time and very depressed. And also, this person really loves horses. Well, then I'm going to look for equine therapy instead of in the office therapy, right? And I'm going to look for a way to incorporate what this person likes because they have their individual strengths, interests, and talents. And I'm going to use those individual strengths and talents to help them. So learning that, somebody really likes animals, well, it's part of your connection with them, connecting them to the Humane Society or, an animal shelter. Right. And so same thing with gardening, same thing with books, right? So we have to really get to know people on an individual level, what they are interested in, so that our interventions that we work with them to create are things that will speak to them and they'll feel good about, right? The next one is strength-based. And strength-based is, I kind of just said it in individuals. We're having conversations with the people that we're working with to find out what is it that you enjoy doing. And if you talk to somebody, what are your strengths, that's already in conversation. Right? But if you say, well, tell me, what do you like to do when you have a free time? Or what do you do on your weekends? Or, maybe you haven't been doing things recently, but in the past, what did you like to do? You liked art. Well, let's talk about what kind of art, and really, we want to find out information that way. And then we use those strengths to help us meet our needs. The next one is additional care or persistence.
Yeah. I'm sorry to interrupt. I think you're fading in and out. So are you having internet issues at home?
Not that I'm aware of.
Okay.
Am I fading in and out?
Sometimes I've noticed that. I just wanted to make you aware in case we lose you, you might have to jump back on.
Okay.
Thank you.
All right, let me know, okay? You have my number, right? My cell phone number? Okay. Okay, the next one is unconditional care. And unconditional care is one that's a big challenge for us because of, again, the barriers within our organization. And so some of those barriers look like if people don't show up, then we're going to have to close their case, or 3 strikes and they're out, and we can't see them anymore if they don't show up, right? And so we're not really able to do this whole persistence thing that we really want to be able to do, because we don't have the flexibility to do that. Our organizations don't allow us to do that. And so we have to, again, remember, you have to have that organizational support in order to successfully meet clients where they're at, right? And so we have to work on that. Next one is natural supports. And so natural supports, and actually we're going to do an activity on this one, a poll. Okay. Karina, are you ready for the poll?
Yes. So with this one, you want to think of the biggest crisis in your own personal life and how did you get through the crisis. The first one is family, friends, faith, and then paid professionals. So if you can take a couple minutes to answer those, that would be great. Thank you.
Thank you. Yeah, so you don't obviously have to share the crisis, but just think about the biggest crisis you've ever had in your own personal life. How did you personally get through it? This is not about a client. This is about you personally, right? Did you look to your family? Did you look to your friends? Did you look to your faith? Or did you get your support from a paid professional with an advanced degree?
We still have people answering, so we'll give them a little bit of time.
Okay. Some people are saying multiple things, right?
Okay, we have about 30 seconds left, so if you haven't answered, please go ahead and respond. Thank you. Okay, it looks like our everyone has answered that can answer, and it seems like our biggest percentage went to family. The second highest percentage went to faith, and then friends, and then paid professionals.
Okay, thank you. Yeah, so if you look at this, when we think about the biggest crisis that we've ever had in our own personal life, the majority of us get through the biggest crisis with our families, Karina said. Then the next highest was people got through the biggest crisis with their faith, and the last one was with their friends. and then the next one was with their friends, and the last one was paid professionals in advanced degree. So then we have to kind of just take a moment to think about this. If most of the people on this call get through our biggest crisis through the assistance of our family, our friends, and our faith, why do we think that the best way that the clients that we work with can get through their biggest crisis is through us, through paid professionals with advanced degrees? So we have kind of mastered how to get through crisis because we're all here on this webinar and spending time together this morning, right? But we haven't really helped our family, the people that we're working with, the clients that we're working with, we haven't taught them to access those same things that have been so successful for us, right? And I know there's lots of, again, barriers to this because many of the people that we work with, they don't have support systems the way we do, and they don't have access to their family, and maybe they don't have a lot of friends, right? But if we're not even trying to help them achieve those things or work on those things, we're not helping them get to sustainability. We're teaching them to be reliant on us, on our formal supports in our system. And we know that we can't keep people in services forever, right? So at some point, they're going to have to be on their own. So we should be teaching them how to be independent, right? And that's part of our responsibility in Wraparound. So you will see on your service plan, when you're implementing Wraparound, that you would be connecting people to support groups, to a bowling club, to going to church and volunteering in their church, or to doing family therapy with a parent that they've lost touch with or a sibling they've lost touch with, so that they can have those conversations and recreate those relationships so that they have support in the future. It's really all about support, right? The difference between somebody who needs treatment and somebody who doesn't need treatment when you talk about crisis is the person that has access to support, right? That's the difference. Thank you, Karina, for showing the poll. I'm going to go back up to the slide and talk about community-based. And we've really already spoken about community-based because when we talked about one of the guiding, those values, those core values for system of care and for Wraparound, community-based was one of them. And that just means people are able to access services and supports within their own community. So something is accessible to them so that they can get support and services and supports whenever they need them, right? The next one is team-based. And as I've mentioned already, Wraparound is a team-based approach. And being a team-based approach just means that everybody who's involved in the life of that client is sitting around the table together, brainstorming how we're going to help the client get through their biggest challenges and their biggest crisis, right? Then we have collaboration and integration. Again, we spoke to this a little bit when we talked about the system level about collaboration. The collaboration in Wraparound happens at the client level. So if there's probation, they come to the table. If there's somebody from the educational system, they come from the table. If there's physical health conditions, representation comes to the table, right? Behavioral health, mental health, substance use, therapists, they all come to the table so that together we can actively brainstorm, right? But then in addition to the professionals, we also look to get those support systems to the table. Because if we can figure out, what he or she, the client, will do when they're feeling down, and that means going for a walk with a neighbor, well, the neighbor needs to know that not only that they need to help this person when they ask to go for a walk, right? That this person is really reaching out to, I want to spend some time with somebody, so will you go for a walk with me, right? The collaboration and integration is just, you can see if you're all sitting around the table, then you're all collaborating and working together. And that's really what it's about. In a perfect world with Wraparound, we would all be working off of the same plan. It doesn't really work in the state of Florida because different systems require different plans. So if there's probation involved, then probation has their own plan, right? But we can integrate or collaborate with those plans to make sure that whatever requirements are on the probation plan are also on the behavioral health plan, right? And then the last principle of Wraparound is outcome-based and cost responsible. And that just means we're not just making referrals to people to provider agencies without really thinking through, does this client want to do this, right? Because that takes a lot of resources and we get poor outcomes. People don't want to go to services. So, in the past, we might have said like, oh, well, you really need to go to therapy, and I made a referral for you for therapy. Well, if the client's really not interested in therapy, then we're not going to make that referral, Because why would we? If we do, they don't show up. We wasted their time, the therapist's time, my time, because I put it on my plan, right? And the client didn't follow through. So it's more about like making decisions based on what the client wants in a way that's going to get us the best outcome that we're looking for. Okay. The wraparound is a phased approach, and there's 4 phases in the process. And the first one is the engagement phase and preparation phase. The second is planning. The third is implementation. And the last one is transition. And so when you're thinking about the engagement phase, it's actually the most important phase in the wraparound process. I think that many people who work in the role of case manager don't necessarily stop and slow down and take time to get to know somebody. They're just walk in there and, oh, you need this, you need housing, you need this, whatever it is that the client needs, without really stopping and slowing down and getting to know them. And wraparound will only be successful when you stop and get to know the client, because that's when you understand what is it they really want to focus on, what is it that they like to do, and how can I incorporate more of what they like to do in their life so that they'll be happier. I remember I was doing a training, I think it was in Palm Beach, it was either Palm Beach or Tampa, and somebody in the room was working with adults, and the adult client was complaining about their housing. And, oh, my roommate this, and I can't stand this, and, this place is gross, and complaining about their housing. And so the case manager just took that as, well, I need to find new housing for this client, without actually having the conversation of, do you want me to look for housing? They just said, obviously, this person's upset, I'll just find them housing. And found housing for the client, made arrangements to move the client, and the day that they were supposed to move, the client finally had the guts to say, I don't want to move. I like where I live. And the case manager was surprised and said, well, you were complaining about it, so I just assumed you didn't want to live there anymore. And the client said, no, I was complaining, but no, I want to live here. I don't want to move. And the case manager had done all of that work without just actually having the conversation with the client, right? So that engagement piece is, we really have to just stop and slow down and get to know the person, get to know their strengths, interests, and talents, because those strengths, interests, and talents are what's going to make all the difference in the services that you provide in the future. Also in engagement, we're doing what's called a strengths and culture discovery, which is the assessment in the wraparound process. And so we're doing a conversational assessment to figure out, create like this narrative of their life, to figure out what they enjoy doing, what they're worried about, and how we can incorporate those strengths into their needs, right? You're also beginning to pull the team together and finding out who the client wants to be involved on the team. Then there's the planning phase, which is just having your regularly scheduled planning team meetings where you pull the whole team together. The implementation is you're just working the plan, right? And in Wraparound, the plan is a fluid document. So 1 month, we might say, okay, this month we're going to work on this goal. And then the next month that might change. So you update the plan on a regular basis. You don't write a service plan or a treatment plan and then visit it 6 months from now. You're looking at it constantly and saying, okay, we achieved this, we didn't achieve this, let's change this, let's add this, and let's keep moving forward, right? And then finally is transition. And transition speaks to the person has gained all the knowledge and skills that they need, and they're moving forward. And so I see a question, is the client involved in the wraparound meeting? Of course, the client is absolutely involved in the wraparound meeting. In wraparound, we say nothing about me without me. So we don't staff clients when they're not present. We have conversations with the client about what they want, right? Because again, they're guiding the process. So that's a really good question. Thanks for pointing that out. Okay, so let's just talk a little bit about the wraparound. Let's just talk a little bit about the wraparound process, right? In order to begin implementing wraparound within your organization, staff would go through the 3-day wraparound 101 training. But then there's also a really important piece to wraparound that's called coaching. And we do that for what we call fidelity to the model. And fidelity to the model means that we are going to implement wraparound as close to the way it was designed as possible. And the closer that you implement the model to design, the better outcomes you get, right? So you can't say you're doing wraparound because if you only went to a 3-day training and then you never changed anything about your practice. you were trained in wraparound, but you're not doing it, right? So the way that we know that you're doing wraparound to fidelity is through this coaching model. And the reason that we use coaching and wraparound is because what you see here on the slide. So if you just went to a training, like today, you're at a training, right? So I'm talking about theory. I'm talking at you guys because of the format that we're in, sadly, right? And so from this training, you'll improve your knowledge by 10%, right? You will be able to demonstrate some new skills 5% of the time because of just this conversation that we're having, right? But then when you go out into the field and use it with your clients in the field, you're going to change your practice 0% of the time, right? Now, if during this training, we also did some demonstration, like you watched a video about how to use a certain technique, or I did a role play with somebody, which I can't do that in my house, but so you would increase your knowledge by 30%. You would be able to demonstrate new skills by 20%. But then again, when you go out into the field, you're just going to go back and do what you've always been doing, right? No change to service implementation in the field. Now, if there's theory and discussion plus some demonstration, and then you guys actually practice a skill and get feedback on that skill. And we do that a lot in Wraparound 101. You'll increase your knowledge by 60%. You'll be able to demonstrate the new skill 60% of the time. But then research shows that when you go into the field, you're only going to change your practice and use it in the field 5% of the time. However, if you go to a training and you have skills demonstrated and you practice yourself and get feedback and you get coaching during this process, you increase your knowledge by 95%. You can demonstrate new skills 95% of the time. And when you go into the field, you're going to use your newfound skills 95% of the time. And so we're looking to make changes to practice, which means that we have to implement coaching as part of the process, right? So Wraparound has a strong coaching component as well as a training component.
Julie, we did have a question.
Okay.
The question is the client at all Wraparound team meetings?
The client is at all Wraparound team meetings. Yeah, you wouldn't have a meeting without a client present. I think actually now is a really good time to take a break. That's okay with everybody? You want to do that? Is this okay?
Yes, so we're going to take a 5-minute break, and everyone can be back about 3 or 4 after 11. Thank you. Okay, I'd like to welcome everyone back. And Julie, we did have one comment. This is a wonderful presentation. I work in an inpatient facility. Would we be able to get this wraparound training? We have individuals who have been found not guilty by reason of insanity and need to be educated about the community process as we sometimes discharge residents to the community.
Yes, yeah, absolutely. That's a good population to work with when it comes to wraparound is stopping people from going into residential, or when people are getting discharged from residential is a really good place to, because, you know, that transition is really important. And if you do it right, you can make a big difference in the life of people. So any support that we can offer in those transitional periods, either going in or coming out, or stopping somebody from going in, or when they come out and re-enter the community is a great time to do it. So yeah, you have my information. I can put my email address into the chat.
We'll have it during the conclusion slides. I'll have your email address for them to contact you.
Okay, perfect. Okay, so we're ready to move forward then. Thank you for the question. I think somebody put information in the chat about a client that was interested in photography and how they put that onto their service plan or treatment plan, and then it helped that client move forward. And then another one who wanted to volunteer. And those are really good examples. Thank you for pointing that out. Sounds like some of you guys are already doing this stuff, which is awesome, right? So thanks for sharing your suggestions. So I wanted to just kind of go over a typical family that we work with, so you get a sense of, you know, why we really need to do a better job of this integration and coordination and collaboration, if you will. So this is a family called the Johnson family, and the identified client is Maggie Johnson. Maggie is 38 years old, and she's married to Bob, who's 39 years old, and they have 3 children. So Bill is 14, Sam is 12, and Sally is 5. Right. So when you look at the family, there's a lot going on there, right? Because I have 3 children like that too. Not a 5-year-old. I have twin 13-year-olds and a 17-year-old. But looking at the strengths of this family, so the parents have been married for 15 years. They have support through their parents, so the grandparents of the children live in the area. Maggie has a home cleaning business, and so she's a bit of an entrepreneur that way, though she's sporadic with working. The family really has done a good job of being resilient, right? So they kind of land on their feet when they do have challenges. Bob has been sober for a year after 10 years of being an alcoholic. The children like each other and support each other, and the family overall is focused on education. They want to prioritize education. So let's talk about the major needs for Maggie and the family. So Maggie has a history of major depression, which has been untreated off and on. She is in need of some crisis stabilization currently. She needs help some support with her mental health condition because she's having suicidal ideation. And she also needs help just managing everything happening with her family. Bob has is verbally and physically abusive to children. He's unemployed, and he says that he's unable to hold a job because he's stubborn about authority. Bill is involved with the probation system, he has arrests for breaking and entering and shoplifting and theft, and he's a little behind in school because he's been in so much trouble legally. And then the 2 younger siblings, the other one has some intellectual developmental disability, possibly autism. The school's really been unable to slow them down, and they need help educationally as well, right? So Maggie has a lot on her plate. You feel that this situation is, right? So these are the needs. And Karina, will you use the poll?
Okay, so we want to rate the family based on complexity, 1 through 4, with 1 being least complex and 4 being the most complex. And Julie, you're still like breaking up a little bit.
Really?
Yeah, so I'm not sure what's going on.
I'm sorry. I don't know what to do about that. I switched over to my hotspot.
Eric, should we have her call in? I don't think he's on. Talking to my.
You want me?
Yeah, we might have to get you to just call in and use the audio that way. If it continues, I'll just let you know. Are you having internet issues
No more than usual.
at home? Okay.
Yeah. Are people using the poll? Karina has the poll.
We still have a big group that's still answering. Julie, our IT person suggested that maybe you disable the video if we continue to have problems and see if that helps.
Turn the video off?
Right.
Okay.
Getting ready to close the poll. I'll give you guys about 15 more seconds. Okay, so we had a very low number for not complex. Our highest 2 were complex as the highest, and then very complex as the second highest.
Okay. All right. So based on this situation, you guys are feeling like it's pretty complex, either complex or very complex. Okay. So that's interesting, right? So that gives us a sense of, based on the clients that you currently work with, how would you see this client, right? And so it's pretty complex, right? There's a lot going on for this family. Now, I would like for you just in a second, chat in the chat box, put like, very few of you said that, or some of you did, but not everybody said that the client was very complex. So why did you say it's not very complex? Like, what's going right for this family and this client that it's not very complex? Those of you that said it's complex or a little complex, what's going right? What is this? What are the positives for this family? You can just put it into the chat.
So we have well serious could be a hint, but my experience is complex. Still having some audio issues. They are in the community still. They are intact. Family, sobriety, resilience, family support of all four grandparents, year of recovery of father. Mother and father are sober. Neither parent involved in the criminal justice system, and DCF is not involved.
Okay, right.
Support system with extended family, children supporting one another. They're all coming in. You want me to keep reading?
No, that's good. Right, so there's a lot going on. Thank you. There's a lot going on that's right for this family. Even though they're pretty complex and we're aware of it, there's a lot going right? And so that's what we want to be able to look at too, is what are those positives and how can we use those positives to help us meet the negatives. And you guys were able to come up with a lot of positives in a really short period of time, which is awesome. So good job. Yourself a little pat on the back for that one. Okay, so now let's talk about who might be involved from the community to help this client, right? The first one, well, obviously we need adult mental health involved, right, for Maggie. Then employment services for the dad, right, for Bob. AA for Bob, they're having housing issues, so, that's the family. There's schools involved, right, for the younger children, so 2 schools. The family's involved in child welfare because of Bob's verbal and physical abuse. Bill, the younger child, has juvenile justice involvement. The younger children have mental health issues, so they're both involved with children's mental health. And then one of the children is possible autism, so there's developmental disabilities. So when you look at all of these people that could be involved with this particular client or family, it's almost like 15 people, 15 helpers in the system, right? That's a lot, right, if you think about managing all of that. So now let's look at the services that we probably would offer this family, right? So Mom, Maggie, is occasionally in crisis. She's been referred to a psychiatrist. She went once, doesn't want to go back, but she should go monthly, right? She needs to attend weekly therapy to maintain her, to decrease her depression, right? Housing, they're trying to find safer housing. Bob goes to 4 AA meetings a week and sees his sponsor twice a week. Bob is court ordered to anger management because of the child welfare involvement. Bob needs to go to vocational services for pre-employment skills to learn some skills. The children are in therapy. The children have IEPs with the school, right? There's child welfare, so they will have to work with child welfare. Bob has been removed from the home, and so they're doing reunification, which is family therapy and supervised visits. So that's time intensive too. And then juvenile justice for Bill, the 14-year-old, right? So there's a lot going on here. Okay. Now let's look at the monthly appointments that, this family would benefit from, right? I see somebody's typing in there instead of needs to, could benefit from. So I'm going to incorporate that language. Thank you. So the family would benefit from these programs or these services, right? So the first one is, well, child welfare, they need to, right? But psychologist or therapist for Maggie, she could benefit from seeing a psychologist. Psychiatrist, she could benefit from seeing a psychiatrist. That's 1 time per month. Then you look at Bill's, which is the 14-year-old therapist. It's been court ordered, so that's 1 time per week. Restitution has been court ordered. That's 1 time per week. Appointments with probation and school, 1 per month, which is required. The children, the younger ones, are going to therapy, and so that's 1 time per week, but there's 2 of them, so that's 8 appointments. Dad, anger management, which is court ordered, so that's 1 time per week. And then just some ancillary, vocational, housing, medical. We didn't even include AA or sponsor visits in this total, but so this family, with the services that we felt that this family could benefit from, 31 appointments in 1 month, right? And so if you think about this, we said this family was complex, but not necessarily the most complex. And we're going to ask them to successfully, get to all of these appointments. And then somebody can just type it in the chat. What happens when they don't show up for an appointment? What do we call this family, or what do we say about them if they don't show up for an appointment? Just take a second for somebody to type in there. What always seems to come up is, yeah. So there's too much going on for this family, and right, there we go. So they're non-compliant, right? And they're being non-compliant with services. And it's not that they're non-compliant, it's just that there's way too much, we put too much on their plate, so there's no way they can be successful. And we do this frequently. When you're dealing with families that are complex and involved with multiple systems, or individual clients that are complex and involved with multiple systems, we tend to not pay attention to how many services and systems and appointments that they have, and could we do that? There's no way I could do this. There's no way I could go to 31 appointments with my children. You know, it's not possible. So we have to think about how we can better work with the clients that we're working with, so that we don't put them into this type of situation, which we tend to do all too frequently. Okay, good job, everybody. So let's talk about what mental health conditions are, right? So I'm making some assumptions here that you guys know what mental health conditions are, but really it's just that there's a clinical behavioral challenge, right? That it's usually associated with distress, so it's challenging or hurtful to the clients that are experiencing it. They could cause disability, so they don't function the way that they should. Mental health conditions are biological illnesses, and we don't want to confuse them with somebody who's a bad person. They're just experiencing a mental health condition, right? What we know about mental health conditions has nothing to do with intelligence, right? That it can happen to anybody, that mental health conditions are chronic but not contagious, okay? Although I have heard many parents say, my children have been acting this way and I feel like I caught it from them. Now I feel the same way, or I'm acting the same way. Mental health conditions are difficult to treat because everybody's body expresses their symptoms in different ways. So I can be depressed and cry all the time and not want to get out of bed, and my husband could be depressed and be really angry and grumpy, right? And we both have the same thing. We have depression, but they're difficult to diagnose because we're acting in different ways. And then the same thing with treatment, because I could take a medication and it has one impact on me, and he could take the same medication and it has a completely different impact on his body, right? And so it's not a science, it's an art. It seems as though it's not a science, it's an art, though it is really a science. And then lastly, just a myth about mental health conditions is that we're dealing with somebody who's like a psychopath or a sociopath, and that's not what we're talking about. Many of you guys in the adult system work with clients who are experiencing psychosis, right? And so I just wanted to talk a little bit for a moment about psychosis. Psychosis is, somebody is either hallucinating or they're delusional, right? So hallucinating is when you see something that's not there. Delusional is when you believe something that's not necessarily there, right? And so the symptoms are we hear voices, we see things that other people don't see, believe that things are happening in the world that may not be happening. We have a paranoid perspective on life, and we just have unusual beliefs, or talk about unusual experiences that may or may not have happened, right? And so they tend to be really problematic for people because you believe something that's happening in your world, it's happening, but in the reality, it's not really happening, right? And so some important things to recognize about dealing with psychosis. And as part of Wraparound 101, we do spend a lot of time talking about psychosis because many of the people many of the clients that you guys are working with experience psychosis. But then if you really think about it, were you ever trained in how to work with people with psychosis? And every time I ask a group of people that, nobody raises their hands that they were actually really trained. So we've incorporated it into the training. So just one common myth is that if you talk to people about their psychosis, that you're making it worse for them, right? That you're they're going to be realizing that it's not the right thing. And the reality that there are actual therapies designed for psychosis. We don't really use them much in the United States, but in other parts of the world, they do have therapy for people experiencing psychosis, right? In Great Britain, in Australia, and actually there's over in Tampa, a grant was recently written to work with somebody, to bring somebody, I'm sure now it'll be virtual, from England to teach us, in Florida about some of these therapies for people with psychosis. That talking about it means that you are agreeing with it. That's a myth, right? In reality, just because I have a conversation with you doesn't mean that I agree with it. I'm not colluding to it. I'm simply talking to you about an experience that you're having. And that's really all it is. So if you say that you believe that the government, is after you, I want to hear about that. What makes you think that? And how does that make you feel? And are you scared? And are you nervous? Or are you angry? Tell me about that, whatever it is that you're experiencing. It's just making a connection, right? Another myth is that like a psychiatrist or a psychologist really should be the only people to talk to people about their psychosis. And again, no, you don't have to have a license to be a human being and to have a conversation with somebody, right? If you're going to prescribe medication, then yes, you should have a license, right? So having a conversation and just making a connection with somebody is just a beautiful thing, right? And then also the Western medicine belief is that medication really is the only way to help people with, psychosis. And again, there's lots of research that says that therapy also works. And making connections with people, a lot of the clients that you guys work with, they might want to be very healthy with their bodies. And so if you're somebody who really cares about nutrition and being healthy with your body, you don't want to put medications into your body, which again then comes across to us as they're being non-compliant with a treatment option. But we have to then figure out from a cultural perspective, how do we work with somebody who has these beliefs about they don't want medicine in their body? And how do we work with that, right? And so we have to get really creative to try and figure that out, but we have to honor somebody's culture around that. So let's just briefly talk about addiction, right? Since 2011, addiction has been considered a brain disorder. Before then, I believe most people thought it was just a choice that people were having. And when it's a choice, we get frustrated because we say, why isn't this person making a good choice for themselves, right? But once we realize that it's a brain condition, then there's a greater likelihood that we can work with them to receive treatment and not get so frustrated, if you will, right? Because that's really what we're talking about, is we don't want to be so frustrated with people because it seems like they're not helping themselves or they're not doing what we expect for them to do, right? And so addiction is recognized as this chronic disease, right? So just like diabetes or cardiovascular disease, so it has to be treated, managed, monitored over time, right? There's this long-standing controversy that, people with addiction have the choice and that they're choosing this way. And the disease of addiction kind of distorts thinking, feeling, perceptions, which then makes people behave in ways that we don't understand, right? So it's difficult to understand. Choice plays an important role in getting help, right? A person with addiction has to make choices for a healthy lifestyle, and they have to make a choice to enter, treatment, and they have to make a choice to continue to recover. But there's not like a pill that will cure addiction, right? You just have to kind of choose recovery over an unhealthy path or unhealthy behaviors. And many chronic diseases require these behavioral choices, right? So people with heart disease, if they choose to eat healthy and exercise, in addition to whatever medication they have to have or surgery they have to have, they will have a difference in their life, right? And so that's we have to stop blaming people and, stop moralizing and just recognize that it is a brain disorder. And so we should treat it as such, right? There's a biological reason for many people that have addiction issues, right? Also, when working in the adult system, we deal with clients that, are what we call co-occurring. And so co-occurring is just the simultaneous presence of at least one substance use and one mental health condition at the same time. We sometimes get really kind of confused about this. It's like, well, which do we serve first, right? And so Ken Minkoff, kind of said that co-occurring conditions in the populations that we work in should be like more of the expectation rather than the exception. So we shouldn't be surprised when people present with having this co-occurring. And we can't figure out which one came first, the chicken or the egg, right? We're not necessarily looking to do that. But what we are looking to do is to make sure that we're aware that both of these conditions are, that the client has symptoms because of both of these conditions, and figure out, so how are we going to treat this? How, what's the best way, what's the best course of treatment to make sure that our clients are meeting all of their needs, not just either their mental health or their substance use. And, in the old days, we would have providers that would say, like, I only work with substance use clients. But, now we have people that work with both. I see a question that says, what does IEP stand for? Sorry about acronyms. Individual Education Plan. It's a school plan. Okay, working with individuals that have co-occurring conditions. So this is kind of what we know about people that have co-occurring, that's both the mental health and the substance use, right? Is that they have difficult time understanding sometimes what we're saying, and certainly remembering. And we don't know if that's a function of they were, using substances, or it's a function of their mental health condition. We just know that this is typical, right? Also, it might be difficult for them to recognize the consequences of their behavior, right? If you've been drinking, when you're sober that you shouldn't get behind the wheel, but after you've been drinking a little bit, you believe that, okay, I can do this. Well, if you go through every function of your life and you're using substances or drinking, you're not always making those good choices, right? So there's poor judgment, there's poor planning skills sometimes, and then sometimes, being disorganized or having, limited attention span is also kind of like a result of this co-occurring condition. So what does it mean for us? Meaning, what does it mean for us as providers, right? It means that people who have co-occurring conditions, we should expect that they are at higher risk for hospitalization, homelessness, HIV, getting arrested, and all those other negative consequences. Women, we should expect that there's a greater likelihood or a greater risk that they could be sexually abused or be involved with domestic violence. Parents, there's a greater likelihood that they could be involved in the child welfare system, right, because of the substance use. And then also, that services might be more expensive for this population because they don't join successfully right from the beginning, right? And then as professionals, often this population is difficult to engage, right? So we should expect that. They don't attend treatment all the time. They don't come in for appointments, probably because, they're tired or they just forgot, right? They have higher dropout rates, unfortunately, in services. There's a greater risk for suicide or substance use, and then they have poorer outcomes.
We have a question. Doesn't co-occurring also include 2 or more mental health conditions, but not substance use disorder?
Co-occurring refers to when there's 2 or more conditions. So you can be co-occurring somebody who's having mental health and physical health, co-occurring mental health and developmental disabilities, something to that effect. You would say if somebody has depression and PTSD, that you would say, okay, there's co-occurring depression and PTSD. The way I'm referring to it, though, is a little bit different. We're talking about within 2 different, I don't want to say different systems, right? But yes, it's the same thing. More than one thing happening at the same time is what co-occurring refers to. So yeah, that's a good point.
And we had someone ask if you could rate the Johnson family.
If I would rate the Johnson family?
Uh-huh.
Okay, I would rate the Johnson family as a 3 because there's just a lot of complexity, but there's a lot of strength. So I would say they're a 3, maybe a 2.5, 3, in my opinion. Thank you. Okay, so let's talk about the key roles in the wraparound process. Let's just kind of bring this back to wraparound. When you look at the slide, you see that there's multiple different important players in the process. So let's just talk about them. So the first person, that's the most important person in the wraparound process, right, is the individual or the family. That's the most important person because they're the ones that are driving the process, right? So it's not about what we want for them, it's about what they want for themselves. And so they're in charge. The next person, and in the adult world, you guys refer to them as peer specialists. In the children world, they're like a family support partner or a youth support partner, right? And so it's really important to have this person as part of the wraparound process, because as a helping professional, meaning you're either the therapist or the case manager, right? You are guiding the process, you're overseeing the process. But at the end of the day, the client sometimes needs somebody to go someplace with them or needs somebody to teach them to do something. And the peer specialist probably has already done all of these things, right? So if you're talking about somebody learning how to apply for Medicaid, well, the peer specialist has probably done that before. And so they are going to sit side by side with the client, not do it for the client, but sit side by side with the client and teach them how to do it, right? Because they've done it, so they know how to do it. And so in Wraparound, we talk about this philosophy of do for, do with, and then cheer on. And so the do for piece is right in the beginning when there's a crisis and we're, kind of struggling with that. And so I will do something for you, like I will quickly make a referral, right? But then the do with is when you're sitting side by side and you're saying, I want to make a referral. And I say, okay, well, let's look up let's look on the internet or let's call 211. And I'm not doing it for them. I'm sitting right next to them and we're doing it together, right? So that's that do with. That's when the client really learns. And once the client has learned how to do that, then we can transition to cheer on, which is I just watch the client do it and celebrate that they've learned how to do that and they feel comfortable doing it. And we do that skill by skill by skill during the wraparound process, so that by the time you're ready to transition the client from services, they feel comfortable and they have the confidence that they can do these new skills well, right? And so that's what we're really looking for. And the peer specialist is like integral in that process to make sure that the client is actually learning how to do these things for themselves, because that's really, kind of the most important thing. If we don't do this piece properly and the client doesn't learn these skills, what ends up happening is we'll transition them from services, they'll do really well, they stabilize, and then the next time they have a crisis, they're going to come right back into care. And when they come right back into care, we've completely missed the whole point, right? So now we have to start all over again. So rather than just rushing them through and getting them stabilized and then closing their case, right, we're going to slowly and methodically teach them new skills along the way. So wraparound takes a little bit longer than perhaps your traditional services, but in the end, you get a better result because the client has learned to sustain on their own. And that's really what we're striving for, is we want them to have the skills so that on their own, they're able to do this stuff without needing to come back into the formal system, okay? And so the peer specialist, if you don't have peer specialists within your organization and you want to implement wraparound, that should be part of what you build in to this process. A lot of systems have places where there's peer specialists available, but they don't work within the organization. So if within your community, there's a Mental Health America, sometimes NAMI, the National Alliance for the Mentally Ill, those kinds of organizations have peer specialists that work for them, and you can try and connect them in that way. So the peer specialist might do something like, if this person doesn't have any friends, the peer specialist would encourage them to come to a group at Mental Health America, right, and meet some other people. Or they might say, oh, you like bowling, I like bowling too, why don't we go, let's on Friday, we'll go and there's a bowling clinic and we'll go do that together, right? So they're going to encourage that person to make those connections with the intention of when we bring the client to the bowling club, the client's going to meet somebody else, and then the client and that other person will build a relationship and bowl together, right? And then the peer specialist will back out, right? And so the purpose behind that is to make sure that there's support for this individual before we transition them from services, so that after we're gone, they still have that bowling partner, right? And they still have those people that we've connected them to so that they can live a happy life. Because those are the things, right? The faith, the friends, the family that we care about that help us through our challenges. We have to help the clients that we're working with build up those support systems in a way that they can continue to have those relationships beyond our relationship with them, okay? And that's what, like, one of the most important aspects of Wraparound is the teaching model aspect, and the peer specialist is such an important piece to that. Wraparound wouldn't be successful without pulling in this support mechanism for the people that we're working with. The next one is the case manager, right? And so in Wraparound, the case manager doesn't do everything for the client, doesn't make referrals for the client. Remember, do for, do with, cheer on. So during the time of crisis, I'll quickly make that referral. But once the crisis is averted, then if you need a referral for something, we're going to sit down, we're going to talk about it. I'm going to show you how I might make that phone call. And then I'll ask you, now you make the phone call, let's practice it, right? And so once I know that the client has learned how to do those skills, then I can then begin to think about transitioning them from services, right? And also, because Wraparound is this team-based approach, what we do is everybody around the team has a different responsibility. So I, as a case manager, might be communicating with the probation officer, right? But then say the client also is having issues or wants to, learn how to do a job application. Well, it could be the probation officer, it could be me, it could be the neighbor, it could be the client's roommate. Somebody who can teach them about doing a job application is going to be responsible for doing that, right? It's not the case manager doesn't do everything. You divide it and conquer it together. And what that does is that teaches the client that they can rely on other people to support them, right? So that they're not the only ones that are doing everything and then things don't get done. And as a case manager, I'm not the only one that's doing everything, because if I'm the only one that's doing everything, as soon as I leave out of the client's life, then there's the chance that they're going to fall apart, right? And we don't want that. We want whatever successes that we've made to continue beyond us, right? Okay. And then the next one is system partners. And this is, again, really integral part of the wraparound process, is making sure that you get all those people from all those different systems, as well as the natural supports, sitting around the table. Because if we don't have these people around the table, then the client has to interact with all of these people in different ways, not in an organized fashion, which is confusing for people. If they have multiple systems, because remember, wraparound is really used best for those people on that top part of the triangle, that red piece of the triangle with 2 to 5% of the people, they have multiple system involvement, like the Johnson family, right? They have lots of different systems involved, which is what's confusing. And so we bring everybody to literally one table and sit around with the client and have these meetings where we talk about what is it that you want to work on, and then everybody around the table makes that commitment. Well, I can help him do this in this way, and I can help him do this in this way. And we all make that commitment to help them achieve what their goal is, right? So system partners include those formal systems like the mental health system or substance use system or the criminal justice system. But then it also includes the friends, the family, the neighbors, the clergy or the church, respected community people, right? So those people also have to be at the table, if you will. And it's up to the client to decide who they want to be on their team, right? But if there's system partner involvement, like jurisdictional, like criminal justice or child welfare or something, they have to be at the table, because otherwise the client can get confused and not know what they're supposed to do next. So it's important that when you have multiple systems involved or complex children and families and adults, that you include all the system partners at the table, meaning the professionals. And then additionally, you add in the other people. And the way it works in wraparound is you don't just say to somebody, the client, like, okay, well, who do you want on your team? Who are the people that support you? You don't do it that way. You identify what the need is that the client wants to work on, and then you say, who could help you with this need? And that's when they would say, like, oh, well, my mom can help me with this. Perfect. Then will your mom come to the next team meeting, right? You don't just say, who are your support systems, and they name 5 people, and you say, okay, let's invite all 5 of them. It's more that once the need has been identified, then you identify the person that can help them meet that need, and then that person gets included in the process, right? And so it's really important to know who these potential system partners are, and if the clients that you're working with don't have these people, these supports, then that becomes part of your responsibility to put it on your plan to help them gain and grow support, because that's the only way that we're going to be successful, is if they're able to kind of gain and grow their support system for the future. So how can organizations support the wraparound process? So the first one is, to understand the philosophy and the values is really important. To understand those system of care values and to model that. Remember, those system of care values is, that we're being client-centered and culturally competent, right? And then those wraparound values is, that we're being individualized and the client's driving the process, and that we're focusing on creating natural support systems and things are individualized, right? All of that. That's what makes us know that an organization is supporting the wraparound process. That if you say you want to implement wraparound within your organization, you're allowing time for your staff to go to the 3-day wraparound 101 training. That also you're willing to look at your organization and make any changes necessary to support the model. And that usually looks like you have to change things like maybe your treatment plan or your service plan doesn't allow for focusing on the positive, right? Or your biopsychosocial or case management assessment is deficit-based rather than strength-based, which a lot of funders want to know, well, why is this client in services, like what's going wrong? And we have to do that, but we also need to focus on the positives. Because if we don't include positives in our assessment process, our whole planning process will be negative, right? So organizations often have to look at some of their policies and procedures and some of their forms to see if they support the wraparound process. And then also remember that slide about if you don't do coaching, you're not going to get the good outcomes. You're not going to change your behavior. So if an organization is making the commitment to implement wraparound, that means that they're making a commitment to allow coaching within their organization. Usually we coach to the supervisor, and then the supervisor trains their staff and certifies their staff. And the coaching takes about 10 hours per person to get certified in the process. And again, we coach to a supervisor, and then the supervisor coaches their staff. Again, we're looking for creating sustainability within the organization, right? And then also we talk about that you have to participate in system meetings in order for wraparound to be successful. And again, remember that same slide where it talked about, okay, at the individual level, staff get trained and they implement wraparound. At the organizational level, we might have to change policies and procedures. We might have to change documentation. The organization is going to support the model, meaning the collaboration of the model, right? And then lastly is that system level stuff. And wraparound won't be successful if you're not sitting at the table and talking about what some of the challenges for implementation are, right? Because we have to make sure that everybody within the entire system understands what wraparound is. Otherwise, we won't successfully be able to make any changes or make any movement, right?
So we had a question from the audience, Julie. How do you assess for confidentiality as you include multiple support?
Oh, that's a good question. So what we do is at the beginning of a team meeting, you have a sign-in sheet, and so everybody signs their name. At the top of the sign-in sheet is a confidentiality statement. Just says everything that happens in this meeting is confidential, blah, 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 right? So we do that as well. If you're working with formal providers, then you would sign a release of information so that, they understand about that. And then at the beginning of a team meeting, you would have a conversation about confidentiality and just say, welcome to be here. We're so happy that everybody's here. We want to make sure everybody understands that what happens in this meeting stays in this meeting, and talk about that. And then also, so there's no binding way that you can say that the neighbor's not going to go and tell everybody else. However, prior to even putting people on the team, that's a conversation that you have with the client. And you would say, something to the effect of, at this meeting where we might be talking about some things that are pretty personal to you, are you the people that you invite? You want to make sure that you trust them and you know that they could be part of this process. It becomes a challenge with things like boyfriend and girlfriends. That makes it really challenging sometimes because, right, today, of course, I will respect your confidentiality, and then tomorrow, when we've broken up, I might not feel the same way. And then there's always the risk of that, especially teenagers with how connected they are to social media. And so, today I'm your boyfriend. Tomorrow, after you cheated on me, I'm going to go on social media and tell everybody about, your mental health diagnosis. And that's a challenge, right? So we have that conversation up front and talk about, like, if you insist on having somebody come to the meeting, then we won't talk about the sexual abuse, or we won't talk about the diagnosis. We'll talk about things that are a little more mainstream to make sure that we're protecting confidentiality, right? So you don't have to talk about all the really deep, dark secrets that people might not want to address. You're really talking about, like, how are we going to get this person to get a job? That's the kind of stuff that we're talking about in the meeting when there's people there that we're not 100% sure about, we can trust. But it's tricky. You do talk about confidentiality, and you say this meeting is confidential. But at the end of the day, you can't really hold somebody to that, other than to make sure that you don't talk about things that are really super personal during that time. Okay. Any other questions? Okay, I want to read this statement to you a couple of times, right? So we're coming close to the end here, and we've talked a lot about what Wraparound is and does, and I think it's an important parting thought for you to recognize the difference between support and treatment, right? So a person without support looks a lot more like a person in need of treatment than a person with support. I'm just going to say that one more time. A person without support looks a lot more like a person in need of treatment than a person with support. And that's what's really important for Wraparound, right? Is we have to make sure that we are helping connect people to support systems, because in the future, if they have support systems, when they have a challenging situation, they can lean on that person and they won't need to come into formal services. But if they're all alone and they have no support and they feel like they need help, then they're going to come back through our doors. And we don't want that. We want to keep them in the community and safe and comfortable with the people that they have chosen to put into their lives, right? And so it becomes our responsibility to create that sustainability.
Okay, we have a question. How are you able to monitor fidelity? I know many unethical large agencies, unfortunately.
Okay, that's a good question. So the way that we monitor fidelity is through the coaching process, and that we have like these coaching tools that when somebody's going through the process, we will assess their skills and give them scores and then give them feedback. And so once somebody's been certified in the process, then the coach is responsible for continuing to observe their staff in person. Like that's the commitment you make when you become a Wraparound coach. Wraparound is something that many of the Medicaid managed care associations are starting to reimburse for in the state of Florida. And we're figuring out like what that ongoing fidelity measure will be. Wraparound is also a national initiative, and at the national level, there's something called the National Wraparound Initiative, NWI. You could Google it if you wanted to. There's more than you ever wanted to learn about Wraparound on that website. And on that website, they have access to tools. One of them is called the WIFI. It's like the Wraparound Fidelity Index, and the WIFI Easy. And then there's a tool called the TOMS, which is looking at organizational management. And so there are tools that assess on an ongoing basis for fidelity. It's whether or not the organization or the system wants to follow through and use the tools, but it's up to the supervisor and the coach to make sure that the organization is implementing to fidelity. I'm reading it text. This is a problem that go ahead.
A comment and a question. This is a problem that I'm sure you must be aware of. Will they do the work to monitor?
Yeah, I know. That's a challenge, right? That's really a challenge with any evidence-based practice. For the state of Florida, with the the implementation and scaling of wraparound across the state, we've really put the onus on the funder first, and then secondly on the coaches within the organization. And so it's once you become a certified coach, then you are going to be using this model, and then the funder, because the funder will come out during monitoring to say, okay, so show me your, your coaching materials, show me what, when the last time you did the coaching tools and the skill sets. And so we work with the funders to help them know what they should be looking for during the monitoring process. And so, for example, like all the managing entities that implement wraparound within their regions, they have incorporated some of these wraparound values into their monitoring tools. So when they come out to do an audit or, a monitoring visit with one of their providers, they're going to say, show me your strengths and culture discovery, show me your coaching materials, and they ask that way. So we've kind of worked it into the existing system to make sure that we can monitor fidelity on an ongoing basis.
Okay, we're going to open up the board for some last minute questions before we end. So if you have any questions, go ahead and send them through so we can answer them.
Oh, and there's my information. You can see my email address. So if you have any questions or you are trying to figure out if your organization can begin implementing wraparound, you can just shoot me an email and I'm happy to help you try to figure it out and assess for that.
We had a comment. I have staff that have been doing wraparound for 5 years, and I'm always doing refreshers on wraparound and also invite families to come in and observe the WCM as facilitator. And real quick, we need you to show your resources again. And the last one, can you repeat the items that the MEs will be looking for?
Okay, so there's the references, if that's what you're looking for, and the items that the MEs will be looking for. So I think I believe that most of the organizations can have access to the monitoring tool. There's a toolkit, and I don't think it's on this list here, but I'll type it into the chat right now. There's an online toolkit, and on the online toolkit for wraparound, there's monitoring tools listed on there that so you can just look it up. But they'll be looking at things like, were there signatures on your strengths and culture discovery? Did the family approve the strengths and culture discovery? They'll be looking at any of the coaching tools that you would be using and implementing, or that the supervisor would be using and implementing. They'll be looking for the wraparound documentation, so a service plan, a transition plan, that, like those types of documents, including the strengths and culture discovery. And then they'll be looking for things like agendas for team meetings to make sure that you are having a written agenda in advance. So like all the individual aspects of the wraparound process were kind of incorporated into the monitoring tool when they're monitoring for that. Let me just type in this toolkit.
So a couple of people had asked about the references, and the presentation is posted on our website already. So if you want to download that, you can. And we also will have the recording available in our training library, hopefully in the next couple of weeks. And then as far as CEUs, I'm getting ready to go over some conclusion slides, so if you can just bear with me. Julie, did you have any other thoughts you wanted to add?
No, I just want to thank everybody for everything today. I'm going to type information into the chat about how you can find the toolkit and the information on the toolkit. So thank you all very much.
Julie, thank you so much. You did a really good job with answering the questions along the way. And I'm actually going to go through the CEU information now. So if you can bear with me, When we conclude the webinar today, your browser is going to take you to an evaluation on our FADA website. If you want to receive CE credits or a statement of credit for this event, please remember to complete the evaluation. Here's Julie's contact information and also her resources if you want to take a quick picture with your phone. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for licensed healthcare practitioners, you must provide an accurate Florida Department of Health license and prefix number the first time you register. So if you haven't created a profile with us, you would need to go to our site and look under our sign-in where it says haven't registered yet to actually create a profile, or you will not be able to take the evaluation. Also, if you do not use the same email address that is in your profile, it does not match up your credits. So it's important that you use the same email address to attend that you have on profile. Once you register or sign in, you'll be able to take the evaluation. And again, a thank you email will be going out shortly so that those who do have a profile will have an opportunity to click on the link. The evaluation does close on midnight, Thursday, August the 20th. Once you complete the evaluation, you will get a confirmation that it was successfully submitted. Just one note is that we do not email statements of credit. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile that you will need to go in and print yourself. And again, Julie, we want to thank you for today. And one last thing is we also want to thank the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education, and have a great rest of your day. Thank you.